Our next topic of discussion is blood and blood disorders. The first thing I want us to look at are these blood tests. If you don't know these numbers, memorize them, because you may well have to know these to answer questions on NCLEX. So the normal white count, about 5,000 to 10,000. And what do white cells do? Fight infection. So if a patient had a white count of 1,400, what would it mean? It would mean that they are immunocompromised, at risk for infection. If they had a white count of 14,000, what would it mean? It would mean that they have an infection. All right, now what do platelets do? Platelets clot. They are clotting factors. Normally, there's a pretty wide range of platelets, about 150,000 to 500,000, and these are all per cubic milliliter. Now, suppose a patient had a platelet count of 15,000. What would that mean? It would mean that they would be at high risk for bleeding. Now, RBCs, red blood cells, run about 4 to 6 million per cubic millimeter. Note that men have slightly higher than women. So I wonder why women have fewer red cells. That's right, women lose some every month, so that tends to make their red count slightly lower than men's red count. You want to look at hematocrit. Hematocrit measures the part of blood that's red cells. So hematocrit is the percent of blood that's red cells. And it runs from about 36 to 54%, again with men on the higher side because of the same reason. Women lose blood on a regular basis. If we take a look at this picture, we note that tube A has a hematocrit of about 40%. Now the red part is the red blood cells, and the yellow part above that is the plasma or the fluid, the liquid. In tube B, there is a hematocrit of 60%. Now it's very possible that patient B simply has more red cells. It's also quite possible that patient B is dehydrated. So remember that you always need to look at fluid balance when you're interpreting hematocrit, because the other part of blood is liquid. And if you're dehydrated, it will be artificially high. Now, hemoglobin measures the actual oxygen-carrying component of blood. And this runs from about 12 to 18 grams per deciliter. And again, women are a little lower than men for the same reason. They are not going to ask you on the exam the exact values. They're not going to give you a question that says, what's the normal white count? But they might give you questions that look like this one. The client has the following lab values: an RBC of 4 million, WBC of 4,900, platelets of 25,000. What nursing action is of highest priority because of the lab values? Number 1, maintain bed rest. Number 2, adhere to protective isolation. Number 3, give no IM injections. And number 4, encourage the client to drink fluids. So look back and see which of those values is most abnormal, and it's the platelets. So the answer would be number 3, give no IM injections. Now the white count was 4,900. That's borderline low. It's not low enough to cause a serious problem. All right, here's another question. The client has the following lab values: an RBC of 3.8 million, a WBC of 1,800, and platelets of 200,000. What nursing action is of highest priority because of the lab values? And we actually have the same 4 choices that we had in the last question. If we look at this one, the lab value that is most abnormal is WBC. This WBC is 1,800. That's very low. So the answer here is number 2, adhere to protective isolation. So these are examples of the way they might ask you questions. They're not going to ask you specifically what is the normal white count. They're going to put that data in a question, and you need to be able to know whether it's normal or abnormal. Now I want to talk a little bit about blood types and blood groups. So some of you are type A. So people that have type A blood have A antigens on their red cells. Some of you are type B. If you have B blood, you have B antigens on your red cells. Now, A people I know are very generous. So would the B types want to get a transfusion of A blood? No, because they would make antibodies to fight those antigens on the red cell. And likewise, A would not want to get B blood because they would make antibodies to fight the B antigens. Now, some of you are AB. AB means that you have both A and B antigens on your red cells. Now, if you were AB, you could receive blood from person A or B because you have both of those factors. But you could not give blood to the A's or the B's because you have the other factor as well. And you cannot receive something that you do not have. Now, there are many, many people out there who are type 0 or type O blood. Usually with type O is the most common type of blood. And what this means is that you have naked red cells. And that's why I call it type 0. It means you have no antigens on those red cells. Now, could type 0 or type O get blood from the A's, the B's, the AB's? No, because they don't have those factors. Could they give blood to the A's, the B's, the AB's? Yes, because they got naked red cells. There's nothing on them that anybody can fight. Now, in addition to the AB0 grouping or ABO grouping, we also have Rh factor. And Rh is quite simple. Either you have it or you don't. If you have it, you're Rh positive. If you don't, you're Rh negative. If you're Rh negative, you should not receive Rh positive blood. All right, so now let's think about the person who has everything. We have the person who has A and B and Rh. This person is AB positive. So this person has got it all. They are known as the universal recipient. And let's think about the person who was missing everything, was no A, no B, no Rh. This person is O negative or 0 minus. This person is the universal donor. It's very important that you remember who's the universal recipient and who's the universal donor, because they have questions about that. So AB positive has got everything. They're the universal recipient. And O negative, 0 minus is missing everything. Those are the universal donors. Let's do a question related to that. The family of a hemorrhaging client who's being treated in the emergency room asked the nurse why the blood being administered is O negative. They state that no one in their family is that blood type. The nurse's response is based on which understanding? Number 1, when a client is hemorrhaging rapidly, it does not matter what type is given. Number 2, the client has been tested and this is the blood type. Number 3, O negative is safe to be given to all persons. Or number 4, O negative is a very common blood type. And the answer is number 3. O negative is safe to be given to all persons. That's just another way of saying it is the universal donor. Now, we really try to give patients their own blood type. But in an emergency situation, if someone is hemorrhaging, they're going to get O negative blood because we know it will be safe to give to them. Now, I thought we would also take a moment and talk about Rh as it relates to the baby, mothers and babies. If you have an Rh negative mother and an Rh positive father, about 60% of the time you end up with an Rh positive baby. Now, does this baby have any difficulty, the first baby? No, not usually, unless mother's been previously sensitized. So, baby's born, fine. Now, what happens is mother gets exposed to this Rh positive antigen and makes antibodies to fight it. This usually happens when the placenta separates and there's some open sinuses in there and there's some commingling of the blood. So mother now makes anti-Rh antibodies. Doesn't affect this baby. This baby is keeping her up nights already. And it doesn't bother mom a bit. She doesn't even know she has the antibodies. But this child is so adorable. Next year they decide to have another baby. And this baby is also Rh positive. The only difference now is there's anti-Rh antibodies in mother's system. And these anti-Rh antibodies can cross the placenta and attack the fetus. So they kill the red cells in the baby. Sometimes it kills the baby. Sometimes the baby is born exceedingly jaundiced and edematous. We can do intrauterine total body transfusions and transfuse the baby that way. And sometimes we do that. It is a bit dangerous, but it can be done, and often successfully. But wouldn't it be nice if we could prevent the Rh problem in the first place? And there's a way to do that. We can give mother RhoGAM. So we have to turn back the clock a bit. After the mother's first exposure or possible exposure to Rh factor, we must give her RhoGAM. So if we gave her RhoGAM within 72 hours of the delivery of that first baby, then this prevents the development of the anti-Rh antibodies. It won't take them away when she has them, so it's very important that we do it at her first exposure to Rh factor. So we give her RhoGAM, prevents the development of anti-Rh antibodies. In fact, we usually also give it about 28 weeks of gestation in case there's any premature placental separation, for instance. So we give it about 28 weeks. We also give it within 72 hours of delivery. RhoGAM should be given to Rh negative women who have any kind of miscarriage or abortion. You may not know you won't know the Rh factor of the embryo or fetus that would be aborted. But if it's Rh positive, mother could develop antibodies from that. So with every miscarriage, usually at 28 weeks of a pregnancy and within 72 hours after delivery, she should get RhoGAM. And this will prevent the development of antibodies. If she already has antibodies, it's not going to take them away, but it prevents the development of antibodies. Now I want us to take a look at blood and blood products. When a patient gets a transfusion, they usually get red cells or packed cells. We don't very often give whole blood anymore. We usually give packed cells. Now when you think about it, if just under half of your blood, 40–50% of your blood is red cells, if you were to give 2 units of packed cells, that would have about the same volume as 1 unit of whole blood, so you'd have twice as many oxygen-carrying cells as you would in 1 unit of whole blood. So that's an important consideration. There's another reason that we use packed cells as opposed to whole blood, and that is that if you freeze red cells, they're going to rupture and burst. But all the clotting factors have to be frozen to stay good. So clotting factors are what's in the plasma. If you separate them, they can both be good. You can keep the blood, the red cells at the temperature they need to be at. You can freeze the clotting factors, or for the plasma and the clotting factors, and you could give them as separate products. And so you get much more benefit out of it if you do it that way. Now when we have whole blood, if we had it, or packed cells, these usually don't hang for more than 4 hours. We think that if they stay out for more than 4 hours, there's too great a risk of infection and organisms growing in it because it's a beautiful culture medium. So we usually don't leave whole blood out for more than 4 hours. We can give it faster than the 2 or 3 hours. If someone is hemorrhaging, we can put a cuff around it and squeeze it in exceedingly rapidly if we need to. Now I want to look at fresh frozen plasma. This obviously contains the clotting factors. We thought, but please don't thaw it in the microwave. Plasma contains albumin, which is like egg whites, what's in egg whites. And you know what a microwave would do to egg whites? It congeals it. So we're actually going to thaw this in like a warm water bath. So thaw it over a 15-20 minute period and infuse quite quickly. The longer they stay at room temperature, the more they deteriorate. Sometimes we might see specific factors. There's a product that's been called cryoprecipitate that has, among other clotting factors in it, factor 8, which is the one we use to treat classic hemophilia. Again, that's thawed and infused quickly. Note that whenever we hang blood, it hangs with normal saline. So let me ask you a question. You are a nurse in the emergency department. A patient is admitted who has coffee grounds emesis and tarry stools. You are asked simply to start an IV of saline just to get a line in there. What size needle would you use? An 18 gauge needle. You want to use a large gauge needle. If you can get a 16 in, that will be all right too. But you want to use a large gauge needle. What I described for you with the coffee grounds emesis and the tarry stools was an upper GI bleeder. And there's a possibility this patient might need a transfusion. And you need a large gauge needle for blood. And I think they've asked you on the exam needle gauge questions. So use a large gauge needle if you think there's any possibility the patient would need a transfusion. So trauma patients, bleeding patients, anybody needs a large gauge needle. Blood always hangs with normal saline. Dextrose hemolyzes or clumps up cells, so only normal saline with dextrose. 2 nurses must verify the ABO and RH group, and we're very, very fussy about verifying that. You need to sign that the patient's RH factor and ABO group is the same as what they're getting. If they've been cross-matched, that they are getting the unit for which they were cross-matched for. It's very important to identify the correct unit for the patient. Wrong blood, mismatched blood kills. Now, before the patient receives the transfusion, we'll get baseline vital signs, including temperature. Then you will be taking vital signs frequently during that transfusion. Usually it's Q15 minutes times 2, Q30 times 1, and then Q1 hour during the remainder of the transfusion. Some places it might be Q10 times 3, then Q30 times 2. And what that tells you then is that the first half hour is the most dangerous time of a transfusion when patients are most likely to get reactions. There are places that require nurses to be in the room for the first 30 minutes of the transfusion. So now let's say that a patient's baseline temperature was 99. 15 minutes after the transfusion is started, the patient's temperature is 99. What will you do? Nothing. It's the same as baseline. So let's say we have another patient whose baseline temperature was 97.8. 15 minutes after the start of a transfusion, their temperature is 99. What will you do? Immediately stop the transfusion, because we have more than a degree rise here, which indicates possible transfusion reaction. An elevation in temperature is an early sign of a transfusion reaction. Now, we want to talk about a number of types of transfusion reactions. From mismatched blood, it causes a hemolytic type reaction, so it makes the cells break down and clump up. And wherever you have that clumping, you can get ischemia distal to that, so you can get pain in that area. So a headache could be vessels in the brain, lumbar, kidney, sternal pain could be lungs or heart being affected. You could get the vomiting, dyspnea would be in the respiratory system. Now another type of reaction could be an allergic reaction. So if the donor had major shellfish feasts, shrimp dinners, lobster dinners shortly before donating blood. And the recipient was extremely allergic to iodine. It's very possible that they could get an allergic, even an anaphylactic reaction from that. We can't always match it. I mean, we don't say, all right, what have you eaten in the last few days? What foods is the recipient allergic to? So we have to be alert to that possibility. Patients who are known to be allergic responders may be getting Benadryl before a transfusion. Remember that when you give red cells, you're not giving clotting factors, so you need to be alert. Sometimes these patients, if they get lots of red cells, if they've had a major bleed, may also need clotting factors because they may be deficient in those as well.